So welcome everyone to this afternoon's event. This is part of a series which is being hosted by Christ College and CSAP, the Centre for Science and Policy, both based here at Cambridge University. It's part of a partnership with the Lancet Chatham House Commission on improving population health after the COVID crisis, which is co-chaired by Teresa Marteau, who's also one of the main organisers of the event. So the focus for today's discussion is place and policy making. How can local decision making achieve greater change? And we have got two excellent speakers to lead our thinking on these issues. And I'm just going to introduce each of them in turn. First of all, Dr. Jeanelle de Gruchy. Jeanelle heads the Association of Directors of Public Health and is Director of Public Health for Tameside and Glossop in Greater Manchester. Hailing from South Africa, she qualified in medicine at the University of Cape Town and worked in a number of clinical roles in South Africa and the UK before completing her public health training, including, I think, 12 months at the Department for International Development. And she's joined by Professor Sir Chris Ham. Chris was Chief Executive of the King's Fund between 2010 and 2018. He began his professional life as a health policy academic and held posts at the universities of Birmingham, Bristol and Leeds. He was director of the strategy unit in the Department of Health between 2000 and 2004, has advised various international organizations, including the WHO and the World Bank, and acted as a consultant to a number of governments. He continues to hold a number of senior roles in the health service, including being co-chair of the NHS Assembly and non-executive director of the Royal Free London Hospitals NHS Foundation Trust. So we're going to be talking about, given the health focus here of both of our speakers, we're going to be talking about COVID, I'm sure, the pandemic, some of the different responses to that and the different lessons we might draw out of that. And I'll move the conversation then towards these questions of local involvement and decision-making, and maybe finally onto the sort of any connections we see to the environmental questions and issues that are all sort of concerned in this series. So without further ado, Jeanelle, could I ask you to lead us off?
Well, thanks very much, and thanks for inviting me. And I was just reflecting on my diary both today and this week, and it is interesting. So today I've had meetings with my local council and NHS about our vaccination, what's going on with vaccination, and the ethics and prioritization and so on, right with local communities. So we had the various communities on the call, plus NHS and so on. That was local. Then I had conversations with my Greater Manchester colleagues. I spoke to the chair of Cheshire Merseyside, so regional, was on the Northwest Directors of Public Health call, ducked out of that to go on to SAGE, and during it was emailing DHSC about a policy that will be applied around testing in care homes. And of course, then spoke to some colleagues about the South African variant. So had that international, too close to home, unfortunately, flavour to my day as well. And I think the key thing for me is when we look at how we work as operate as a system, all of that's relevant. Now, I know with COVID, it kind of brings it all very, into one topic, but actually all those different layers in society have relevance, and the information and understanding and decisions that we make at all those different levels actually then impact in people's lives in a local place. And that's really where it matters. It absolutely matters to those individual people, residents in communities in a place. And that's why the local level is just so critical. I just want to, I made up, well, didn't make them up, but I've come up with 4 words really to the topic. The first one was respect. And that's respect for what systems were already in place or are in place, public health and local resilience systems. are actually in place, and there's a lot of knowledge and expertise at a local level in those systems, not just in the local level, but certainly there's a lot of knowledge, expertise. There's a lot of system leadership going on at that local level to bring together coherence in a place. For me, a lot often that respect for the local and what happens locally is just not there. There's not an understanding or respect of that. So the second word was recognizing. So just recognizing what I've said, that the importance of a place and of local communities. So again, with COVID, we had this phrase about a lot of, well, the policies made in Whitehall, and that just doesn't have bearing on local people's lives. Well, it does, but it doesn't take their lived experience into account in a lot of the decisions or policy that is made, and just that raw appreciation of people's lives currently in the face of COVID, and the impact across all elements of their lives is huge, really. So there's certainly local public sector organizations have had to do a big job of coherence, of trying to bring coherence to national policy that comes down in silos. So it's very much that coherence making, but I still think we could do this so much better. I mean, it shouldn't have to come to that, and that there needs to be coherence on all those levels and layers. I think could be done so much better. The third word, which I've used quite a bit, is local. But what do we need to do locally to really try to achieve greater change? So the words I wrote down were organize, advocate, engage, and influence. And so I represent the Association of Directors of Public Health, so a membership organization that is organized, and that is really critical, because I think we've probably done I think quite well to make the voice of the local amplify that nationally, so that organizing, then advocating, making sure we actually do advocate and engage nationally to try and influence what goes on. I think the role of national partners is really, really important, or allies. There are lots of organizations that operate at a national level that are really critical to us, and other advocates like Chris, which has been really great to amplify the voice of local into that national space. I think the NHS is an interesting one within all of that, because it straddles. Well, maybe there's a question there in the local NHS and the national NHS, and how it achieves change with partners on the ground. So my last word was strengthen. If we think there's lots of language of there's a nod of late to the central role, the importance of the Director of Public Health locally. If we're serious about that, then how do we strengthen that role? And critically, how do we ensure sustainable funding for the local, not just the DPH, but also of local government, really, really critical. And at this time, with reorganizing of the whole public health regional and national system, how do we potentially use that opportunity to strengthen the local? I'm not sure. It'll go the other way, and there'll be more centralization actually, and more investment into national, unfortunately, as a consequence. So I'll stop there, but my four words then were, how can local policy making achieve greater change? Needs to be respect of local and recognition of it. Local people need to organize with allies. But part of what we advocate for is to strengthen the local voice and the local leadership in all that we do.
Terrific. Thank you very much, Jeanelle. That's a really great start. Chris, can I go to you for some thoughts?
Yes, thanks, Mike, and thanks for asking me to take part. So my perspective, I hope, is complementary to Jeanelle's. I come at this from the experience I have within the National Health Service and work I've done at the King's Fund with now my former colleagues there. And back in 2015, we published a report called Place-Based Systems of Care, a way forward for the NHS in England. And the genesis of that report was an increasing appreciation we had of the complexity of the organisation of the NHS in England and the fragmentation within that organisation. And that was the legacy of many years of reform by successive governments, which have created a lot of organisational autonomy and also based on a philosophy of market-oriented reforms. And it felt to us when we wrote the report, the organisation was not fit for current purposes, putting it simply, because there was no capacity within the organisation to plan for populations and to plan coherently for the places that those populations lived in, which is why we set out in that 2015 report 10 design principles to guide the evolution of the NHS away from that complexity and fragmentation towards something more coherent, more fit for purpose, more capable of planning for places and for populations. And that has now actually been happening for around about 5 years within the NHS. And today there are just over 40 integrated care systems across England, of different sizes and different shapes. I chair one of them, so I see their evolution at first hand, as well as having the opportunity of working with and alongside some of the other integrated care systems. Each of those systems operates at quite a large scale, on average over 1 million people covered, but each system in turn works through a number of places that are identifiable communities within their borders and within their boundaries. Often these will be boroughs, as across Greater Manchester. They might be cities. They might indeed be counties or towns within counties. There is no single model. There's quite a lot of variation depending on which system you look at. And those places in turn are made up of localities and of neighbourhoods. And typically here, populations around about 50,000, where you have a number of general practices working together in what are now called primary care networks. So that's the architecture. The important thing is purpose. What's all this for? Why is there a focus on place-based systems of care? Well, again, simplifying, they are the basis now for planning, improvements in health and well-being on the one hand, and improvements in health and care on the other hand. And they must involve, to achieve those purposes, partnerships. So some of the partnerships are within the NHS family itself, between hospitals, mental health community, and commissioners. Some, more important in many ways, are between the NHS and local authorities. And these are especially important when it comes to improving health and well-being. And they could also involve the voluntary and community sectors, increasingly playing a part, and private sector partners as well. And what I would say from experience and from the research I've done is that working in this way as a system and in places is not easy. And Jeanelle has hinted at this in her observations on the national orientation of the NHS, because the NHS is a hierarchical system. People at a local level running the services in hospitals and community, they look upwards. The money all comes centrally, voted by Parliament. The accountability is to Parliament. Local bodies are performance managed by the headquarters of the NHS. And that tradition of centralised command and control is deeply embedded in the NHS. Whereas the aspiration to work around places and systems is much more about building these horizontal collaborations and partnerships with local partners in the public sector and beyond. And the two don't always sit easily together. The other important point to emphasize is that integrated care systems have no legal basis. They are coalitions of the willing. They depend on statutory organizations being willing to come together to work with each other around a common focus on place and on population. And that's far easier in some systems than others, but that's everywhere, I would say, it's a struggle. So as well as doing some of this work, I'm a sometime academic in my work and my career, and I was thinking ahead of this session about a way of framing place and the role of places in public services. And it seems to me that they actually sit at the intersection of geography, sociology, epidemiology, and economics. So what I mean by that is you can see places on an app, or more commonly these days, you can download an app and see places. But also places, more importantly, are communities. They're communities of people with many assets and many relationships. Places have different patterns of health and well-being, which reflect the underlying determinants of health in those communities. And the economics, I think, go back to the work of Lynn Ostrom and her analysis of how we can govern common pool resources, govern the commons, to use that terminology, and her insights drawn from empirical work on the management of fisheries and forestries and so on, is that it doesn't have to be through state top-down control or indeed through private ownership and markets. It is possible to manage common pool resources, public budgets for health and care, by taking shared responsibility among those who hold those budgets, by people coming around the table together and finding a way through their locally determined governance to make sure those resources are used effectively for the populations concerned and they're available in perpetuity. That the tragedy of the commons that Harding identified is avoided by that shared ownership and shared responsibility. And I think all of those perspectives can be used to shed light on how these systems and places are operating within the NHS, which we might have time to get into. Last two quick comments, if I may, Mike. In our 2015 report, we referenced the Reith Lectures by Atul Gawande from 2014. And Atul said, we live in the century of the system, rather grandly. I think what he was getting at is the complex challenges that societies face today, whether it's the climate emergency or whether it's COVID or challenges of that scale, can't be dealt with by individuals working independently of each other. They require a collaborative partnership systems response where all the assets and expertise come together around the nature of those challenges. And he was right. If you look at the response to COVID within the NHS and beyond, the response has been that much more effective, in my view, because we'd laid some of these foundations that I've been describing, and that enabled hospitals to work together to provide mutual aid, for example, around the availability of critical care capacity, which has been under massive pressure, and lending support to each other when one has been at the limits of its ability to respond. And mutual aid, by the way, is operated within the NHS across systems and across regions of the country, as we've seen during January, when patients from London, the southeast, east of England, have received care some way away from home, including in the Midlands, because we've been able to operate as a system with that sort of mutual support. There are many other examples in the relationship between hospitals and community, social care and healthcare, and indeed in local government through the work of local resilience forums that Jeanelle, I know, has been very closely involved in. So if we needed a massive challenge to demonstrate why these things are the right thing to do, then we've lived through 11 months, which has confirmed the theory in some harsh practice.
Great, thank you as well, Chris. Again, some really interesting food for thought there, and I think that a very nice sort of set of connections into what Jeanelle is talking about. just before I start putting some questions to the speakers, just a reminder, if you are prompted to raise questions to the speakers, please do put them in the Q&A function. Let me just start with a question about two of the key layers that you referenced, Jeanelle, and you've also touched on, Chris. The sense of central government, and also maybe the centralised parts of the NHS on the one hand, and local government and the NHS on the ground on the other. It's felt at times during the pandemic, and I think particularly in the first few months of that, as if there wasn't much connection, or a very healthy connection, between those two layers in terms of how the pandemic, how the sort of decisions were being made, particularly about lockdown and then the exit from lockdown, and also over testing and tracing. Do you have any thoughts on why that, or whether you agree with that characterization, and whether we've learned the lessons of that kind of what felt like a rather centralized response at times to the pandemic? Jeanelle, do you want to start with that?
Thanks, Mike. So I suppose it's my headline messages were a consequence of me sitting here thinking of over the last year what hasn't been there. And so yes, that even knowing that there was a director of public health, I'm pretty sure nobody kind of in Whitehall kind of occurred to them or thought that, you know, we were of any relevance. And also I think just knowing and appreciating respect for the public health system generally, and what is there, what's been built up over decades in this country and funded, and what's the expertise that's there. I say funded, but in some ways underfunded, or not very well funded, but has been the backbone of certainly health protection for decades, and just getting on with it. The same, the local resilience forums, which Chris and I both mentioned, which is basically local government and police and the other services working collectively for any emergency, whether that's flooding, or something like COVID, or whether it's the Manchester Arena bombing. So those systems are there. So I suppose, and then the NHS, and I think there wasn't real recognition of what was there, and that actually a lot of these systems are in place and have been doing really well. They've just not been that funded, and they've not been funded for surging to deal with this massive issue. Now, a lot of other countries, as I understand it, with COVID, they then surged or escalated the public sector, or what they already had in place. And as you mentioned with test and trace, you know, we went down a different route in some ways. So I think I'm not sure that there was that recognition or understanding of the expertise needed, but also the expertise that was there and could have been strengthened. And I think the ultimate recognition of that, I suppose, is then in the first blaming Public Health England and then doing away with it in the middle of a pandemic, which is possibly the only country, I think, Chris, in the world that's doing away with its public health agency in the middle of the pandemic. Come on to that later. But yeah, so I don't know if I think I strayed a bit from your question. I mean, yes, at the beginning, I don't think there was that respect, recognition, and all the rest. But I think over time, we've certainly, as I said, the other points I was making about organising, advocating, engaging, and influencing, we've certainly done a lot more of that. I think there's been way more recognition of it. I think we now have directors of public health speaking really quite directly into government in various ways, civil service and so on. Our relationship with I mean, Chris Whitty was fantastic. He recognised the director of public health right at the beginning. And so we've always had that and ability to influence. I think my worry now, though, is that it's kind of weird. There's a recognition of the director of public health and the importance of local, but will that translate into actually strengthening and funding and when Public Health England gets redesigned and reorganized, anything that strengthens the local, probably no, not really. That's our real worry, is it'll go back into this COVID as control and command. Although all the the evidence is we've been delivering on the ground, that's been really, really important and critical to the response. But I'm not sure that's quite. I still think there's a disconnect in really recognizing and understanding that, and the implications for it in terms of how you would then design a public health system or a government system that's more devolved and strengthened local government. I'm not sure that that's going to happen.
Yeah, so can I turn to Chris immediately with that point? I'm particularly interested in your thoughts on Jeanelle's last point. Will there be learning, as it were, from the experiences that she's describing, but also more generally your thoughts, because you've written on this, on the relationship, what we've learned about the relationship between central government and the locality in this case?
Yeah, so I mean, the centralised approach that we've been discussing, and that's very much been in evidence in the response to COVID, didn't originate with COVID. We went into the pandemic with one of the most centralised systems of government in the Western world. And I suppose all the inherent tendencies built into that system came to the fore, were in plain sight throughout 2020, and are still very much in evidence today. And I would agree with much of what Jeanelle has said. I think we have suffered as a country in our poor response, as illustrated by the number of deaths from COVID in this country and other examples of weaknesses in the response, because we've had a system which I've described as decision-making by the few rather than by the many. And by the few, I mean a very small number of senior members of the cabinet who have been visibly in the lead in the response. And there's been, I think, a reluctance and willingness to share responsibility with local government, with regional mayors, and indeed the first ministers in the devolved administrations have been quite vocal in their criticisms and expression of concerns at the lack of involvement that they have had in the last 10, 11 months or so. Having said that, I just think we need to be nuanced in our thinking about learning from all of this and where we go, because to make those observations is not to say there is no role for national leadership and there is no role for central government. That would be patently nonsense. Think about the highly successful vaccination campaign that we're in the midst of at the moment. You wouldn't want to devolve that to 40 regions of England or 150 local authorities. In other words, what I mean by that, to be precise, is you wouldn't want to devolve to them the responsibility for planning the purchase of vaccines and arranging for this country to have a supply of vaccines available at the right time. You do that well once, and then you plan through NHS England how you deliver that programme once. But the actual delivery has to take place locally by the general practices, by the local health service organisations working with councils and others who know their places and communities, who can bring their local expertise into this. So, yeah, the intelligent question is, how do you get that balance right? Not just on vaccines, but on test and trace, on the purchase of PPE, on all the other big issues that are being thrown up by the pandemic. And do you have a system of government that is capable of flexing in relation to massive unexpected shocks that we weren't, frankly, well prepared for, and that can use different levels of government, that can build the partnerships that can live in the century of the system, rather than a century of heroic leadership by the few, rather than more collective and distributed leadership by the many?
Can I just flip back to you, Jeanelle, because and I think something you said, almost as an aside, I think really speaks to that last point. You said that you thought that we were likely to go in a more centralised direction, perhaps, rather than in a more, if you like, flex type direction, as which Chris has sort of articulated very well. Can you just give us a sense of why you think that is? You sound slightly pessimistic on that point.
I mean, well, I'd be interested in Chris's answer to that. But say, for instance, if you take the way in which the national politicians come up with a number, and then everything is to chase that particular number, and I don't, you know, so even if we take vaccination and we could take tests and the testing to start with, and then the unintended or unthought through negative consequences of chasing the testing numbers, which I can talk about at length. So now we've got it on vaccination, so I don't disagree with what Chris said about vaccination. However, it goes back to this was all designed nationally by a very centralized NHS, where the public health voice wasn't particularly strong on inequalities, on local, on thinking through all the stuff around vaccine hesitancy and local populations, and also local access, and working collaboratively from the get-go with local authorities in terms of where you cite the vaccination and how you think about it and all that kind of stuff. But no, I mean, we're chasing, it's 10 million or it's whatever million, whereas what we say, actually it's which is brilliant, but also if you're getting 75% or 80%, who are the 20% that you're not getting? So going back to who are those 20%? And we know that that's not random. We know that's not random. We know that's what's driving inequalities and will drive inequalities. But it's this real sense nationally of absolutely having to answer for a particular number. You see it played out of the care home stuff, and then national, despite everything else that's going on in a local system, absolutely wants to get there, say, well, we've offered it to 100% of care homes or something, and then that's everyone then chases that particular thing, and it gets quite siloed. So I guess it doesn't enable local systems to do what they need to do. Another one might be the Liverpool testing, where everything was thrown at that, and then everyone else had to kind of scrabble around trying to do the same. So it wasn't what we wanted to do locally, but it was what national wanted us to do. That kind of stuff, that thinking and that approach is still very much there, and they do recognize the local, but in some ways it's to do what they want to achieve nationally without us being able to influence what is it that we think is important to our communities, and what is it that we're trying to achieve. Does that make sense, Mike, in terms of?
Yeah, no, very interesting. I mean, Chris, do you want to speak to that? Because I've got a follow-up, but do you want to come in at that point first?
Yeah, I mean, I think when I've pondered, trying to analyse and summarise and evaluate the government's record, the big trap to avoid falling into is always invoking the benefit of hindsight, and therefore unfairly judging what must have been a difficult position for any government to be in back in February, March, April. But then I reminded myself that during the course of the pandemic, a lot of things became much clearer than they were at the beginning, and yet still avoidable mistakes were made by the government. So, the delay in locking down in March, given the benefit of the doubt and say, well, there were so many uncertainties at that time, even though there were probably fewer than some people would argue, the government wanted to look at the evidence and make an informed decision, so it delayed. But you couldn't invoke that argument by the time it got to September and the advice that was coming through from SAGE, nor indeed more recently around the issues that unfolded in December and the Christmas relaxations and then restrictions. So it was the difficulty the government found, I think, in learning from mistakes and therefore repeating them. I've given lockdown as an example, but on lockdown, one of the other issues that comes out of this discussion is because decision making was so highly centralized and there didn't seem to be any effective mechanism for getting feedback from people like Jeanelle or from the regional mayors. The original lockdown was relaxed too soon, you might argue, in May, when infection rates were still high in the north of the country, even though they'd fallen to much lower levels in the south of the country. So there was a metropolitan bias in the government's decision making that was a function of that over-centralized system of government and the lack of feedback mechanisms to share the intelligence and knowledge that existed out there, but there didn't seem to be a pull from those small number of decision makers to make use of that. And I mean, just the final point here is, you asked me, Mike, about policy learning. I mean, I think what the pandemic has shown is that there are real weaknesses in the capacity of central government to learn from its actions and to draw on a diverse range of expertise in so doing. So SAGE clearly has been very influential, but SAGE is a relatively narrow group of medical scientists. There weren't others like social scientists in the room in the same way as the medical scientists. And fundamentally, and here I'm echoing what Jeanelle has said, where were the public health leaders with practical experience of how you manage local outbreaks when it came to informing the design of test and trace, to informing many of the other key components that we've relied very heavily on, but actually were ill-designed in the first place because of the narrow contributions of a relatively small number of people. So I could go on. I feel quite passionately about these issues, as you may pick up, but I don't despair. I'm just disappointed that the feedback loops weren't in place, and where they might have been in place, they didn't seem to be working.
Yeah, I mean, there are so many questions that I'd love to put to you about the COVID experience in the pandemic, but I'm going to halt for now, and there may be some more in the Q&A. But
Mike, can I just follow up one or 2 points just on that? I mean, because it's so frustrating. It was so frustrating having lived through all of this and seen it play out. I mean, there wasn't a respect and an understanding of the importance of public health expertise and feed in into the design of those systems. It just, I mean, there just wasn't. And there was an immediate, and whether you want to use the word ideological or whatever, immediate use of the private sector in a large way, and lots of money going towards the private sector, as I said in my beginning comments, and not bolstering and strengthening the public sector. So it would be interesting to unpackage maybe that one a little bit. But apart from not, and I'm afraid still not really recognizing that there is a discipline around public health, and it is, there is an expertise in it, and so people kind of coming new to it and getting very excited about it and inventing a whole new thing. And there are some bodies that have been set up to do that, like the Joint Biosecurity Centre and so on. There is a real churn nationally in people, and it's really not, there isn't so much churn locally, but the amount of times that directors of public health or local authority chief execs are talking to yet another person who's just come in, I've only been here for 3 weeks. I can't tell you how unbelievably quickly those consultancy people kind of come through, or the civil servants get moved around. And that whole thing about the public sector where a poor resident has to talk to so many services about their same story again. That's what we've been doing for 10 months. The local has been doing that international. Now, the politicians haven't changed, interestingly, but all the people servicing those big national bodies, like Test and Trace or some of the civil servants, has churned incredibly. And, a new policy, big policy area, and the person will say, right, we want to roll out community testing with LFDs. It'd be fantastic. I've only been here for 2 weeks. Okay, let's get going. And I mean, that's often what we are faced with. So I suppose they were just some thoughts as well about the reality of some of what we've been experiencing over the last year.
Can I just add one quick one? We talked a lot about, quite rightly, public health. Social care really illustrates these issues very tragically, because fundamentally, as a result of a lot of changes in Whitehall and the organisation of the Department of Health and Social Care, as it is now called, there was no senior social care expertise in the Department of Health and Social Care, which alongside the Cabinet Office and the Prime Minister was effectively running the government's response. And I've heard a lot of reports from people who were in the rooms where decisions were taken, who reflect now on there was nobody involved in these discussions who had any knowledge, either research knowledge or practical knowledge of social care, how it's organised, the risks involved in care homes, for example, the tragic number of deaths that have occurred in care homes. So if there had been, if we had a more capable government with people with the right skills and understanding, and not just the clever civil servants, but public service leaders, care homes, public health, schools, something we haven't touched on, but many of the issues apply equally well to education policy, then things could have been done very differently and more effectively, and far fewer people would have been adversely affected in the way that we've seen.
Can I, yeah, very, very interesting discussion. We could go on and on. There are some very important themes there. Can I just, because I want to get to bring in some other questions, but just the final theme I want to hear you both touch on, to drop this down to the level of the local, and to think about, I suppose, some of these questions about expertise and engagement at that level, Jeanelle, that you started talking about. And I'm just interested in both of your reflections on, obviously, in the context here of the pandemic, whether this has taught us new things about health inequalities in different places, and also the role of the understanding that public health brings to community engagement in particular, because I mean, it's often one of the criticisms of points that's put to public health is often that there's a paternalism almost inherent in the public health enterprise, perhaps inevitably. Does that play against having more popular participation, having people more engaged and more involved in their own healthcare and in the sort of management of their own places? I don't know if you've got any thoughts on those issues, Jeanelle.
Chris, do you want to start with this one and then I'll come in?
Well, I think one of the, if anything good can come out of, it is that we've seen a very vibrant civil society response to COVID. Not just the established community organisations stepping up, but new forms of mutual aid emerging as well, and playing a vital role alongside public bodies in supporting people in communities, providing practical support, helping to combat isolation and loneliness, and demonstrating in the time-honoured phrase that we are all in this together and everybody can play a part in that community engagement. I think local government has a much stronger understanding and track record of these issues than the NHS, but within the NHS we've seen the benefits of that as well. And the fact that councils and health organisations are working together in these integrated care systems and place-based partnerships means the experience of local government is rubbing off on the NHS. So the NHS, slowly but surely, is becoming much more oriented to working closely with voluntary and community sector organisations and supporting them and valuing their contribution. And a specific example of that would be the key role of hospices in working with public agencies in the last year or so. They played a vital part in dealing with the pressures and bringing a set of expertise that isn't already available in the public sector.
Thanks. Yeah, so I suppose public health, yes, and it's well. So in a local authority, we've got the director of public health and a team. And with a massive £800 million funding cuts to public health, those teams are shrinking smaller and smaller, as is local government. And that is a harsh reality. And is that going to change? Not sure. And yet this country is massively reliant on what local government can actually do and what it is doing for the response. But my team is only one small element of it, and they actually have done a lot of the expertise and systems leadership stuff. And so they, and just by the way, I mean, this absolutely demonstrates the importance of public health being in local government and having moved from the NHS 10 years ago, because my team now quite easily engage with, through the children's, the education element, with head teachers, regular interaction with head teachers, whether it's webinars or managing all the outbreaks, supporting the head teachers to deal with all of that. The care homes, we're absolutely working with our directors of adult social services and doing all the outbreak control team meetings, and supporting them, got huge connections into them. The food banks and around humanitarian aid, absolutely, with them. The businesses and the environmental health offices in local government, and engaging with those businesses, and understanding that. And then just generally, because we're in we see a lot of people coming to the council with real issues, with real difficulties, and whether it be trying to get, we can see that, hear about how many come for self-isolation and payment, the very high, just because we know that self-isolation is really difficult for people, something that I think is a real policy issue that this government hasn't grasped or handled, and the eligibility is just so high a bar. So we see those people come, try to get some money or some ability to do it, just don't make the eligibility end of, and yet they are out in the community still working. Then we have the consequence of that with outbreak management. So I suppose the point is, it is sort of public health, but it's not. It's our links all through. And as I said, just came from a meeting with my local NHS. We're in an integrated system locally in terms of vaccination, but we had the voluntary sector on there. We had various other players. And we had the local government communications system, our community champions and so on, with all the local members and councillors. So it really is a massive system that with COVID has absolutely mobilized in so many ways. I think you've got public sector transformation and reform happening in an amazing way. It's just, how do we capitalize on that? And how do we strengthen it? Because at the same time, we're having massive budget cut conversations, and we're busy cutting stuff as well. So for me, that is the question: how do we really build on the positives of, not losing a good crisis, but in an environment where we're going to see austerity on steroids, and local government is absolutely at the bottom when everything gets cut, and we just have suffered the worst cuts over the last 10 years.
So I think this is is it a question of, is it a 1945 moment or is it a 1918 moment?
Well, we all ponder that one. What I'm going to do now is actually just switch focus. So let me put some questions to you that have come in on the Q&A, because I'm just glancing through them now. And one or two of them I think are very pertinent actually to this discussion you're just having. Let me put a question to you from Graham Pendlebury, who's I know a CSAP fellow involved in the Department for Transport. Graham says, all good stuff, but the trouble is, one, I've never met a British government minister of any party willing to cede genuine power and money to local or regional institutions. And two, the popular and media reaction to local variation in service levels is, quote, postcode lottery, it's an outrage, unquote, and an accompanying demand for national intervention to rectify the problem. I'm sure you both recognise both of those points. So we can see this now with variations in the speed and scale of vaccine rollout. How do the speakers think we can overcome these two problems? Who'd like to go first on that one?
So on the first point, if I go first, he's right. If there is no willingness on the part of the government of the day to give power away and to revitalise local government and to think harder about regional elected mayors and what might exist at that level, then it ain't going to happen. But, we might have been sitting here having this conversation in 1991, saying the same thing about devolution. And yet a lot has happened on devolution, and a hell of a lot more maybe about to happen, depending. So nothing in politics, in government is ever certain or unidirectional. events dear boy intervene and upset some of this stuff. On the second point about postcode lottery, as well as the government's lack of understanding of what exists in local government, the point that Jeanelle was emphasising, I think this is perhaps another reason why there was a lack of willingness to work with local government more than was the case. This concern about, okay, some local authorities are good, they're well run, but there are others who aren't. We might end up with unacceptable variation in the local response, which of course then led the government to say, okay, we'll reach for support from the private sector, with a huge amount of public money being spent to bring in the expertise needed to scale up testing and other aspects of the program. Again, that may continue for some time, but I would hope that one of the learnings from all of this is the fragility of public services. After a decade of austerity, most of us have been working in and alongside public services. I've known this for some time. Everybody knows it now because it's an open secret. The depletion of public health teams, the cuts in hospital beds, and the lack of any slack or spare capacity to draw on in the case of a surge. So as we learn the lessons, and if there's more of a willingness to do lesson learning, surely part of that must be about rebuilding, reinvesting in public services of all kinds over the next decade or so to put us in a much better position. Because let's be clear, this will be this won't be the last pandemic of the 21st century. Yeah, I'm not a public health doctor, so I defer to Jeanelle and people who are much closer to this. But it's a safe bet, isn't it, that if we do well, we can learn all the hard lessons from this to position ourselves much better next time round. And next time round might be 2 years, or it might be 22 years.
Jeanelle, do you want to answer that question? Because I've got another one teed up.
Okay, I'll just briefly. I mean, I suppose there is a problem with the centralization, central, local. But part of the problem with the centralization is, and with government ministers and the power and the way that they are judged, is it creates a very siloed, centralized national government. It's unbelievably siloed. And so not only are we sort of getting the stuff, we're getting individual silos of stuff coming through. So, I mean, again, this is just for illustrative purposes. I know I've used testing a few times, but if you take testing, I mean, it might surprise you to know that NHS Test and Trace doesn't have the overarching say on testing even. So some of what happened is that the DfE decided around the testing on schools, and that all of a sudden came down to us. Bayes has its own decisions on testing in businesses, and that just comes down to us. And Test and Trace is doing the community. So even something like testing is no coherent strategy across the centralized government. It comes down in silos, and then the Director of Public Health in the local area has to manage all of that with all our partners and with the and with residents in terms of, well, what does that mean? Where do I go? And then the whole point of testing is, it's not the point. The whole point is managing the transmission and the outbreaks, and testing is only a tool. So why are we, it's not a so anyway, so there's all of that plays out. But I wonder whether so a lot of it is hitting a target, missing the point, and the point isn't it? It's about well-being and the health of the population and reducing inequalities, but that's not really how the government is judged. So so I think there is something about how we. So it isn't in the interest at the moment. It's in the interests of the Treasury to continually fund the NHS, but not to fund local government, which is a health promoting entity, because it doesn't get measured in quite that way. So part of the whole difficulty with the first wave discharge of people into care homes was simply to save the NHS, without thinking about the system or the implications or the consequences of just getting people out and getting them into the care home system. And I was there. That is what happened essentially. So I think there's a lot in the political system that means that government ministers behave in the way that they do, and things are set up in the way, and then that has all these knock-on consequences that I've just mentioned.
I mean, so following up on that, I mean, there have been attempts, I think, in recent years to try to break out of that very siloed approach. And one of our questions relates to those kind of initiatives, things like the Healthy Towns initiative. So this is from an academic here at Cambridge, Martin White, who says, my research had demonstrated significant failures of government-funded place-based public health initiatives, such as Healthy Towns. Government repeatedly throws a lot of money at such initiatives. Are they always destined to fail? What are the viable alternatives?
So Healthy Towns is pretty classic, isn't it? Because actually that was NHS funded, okay. And it was one sort of intervention. Well, that's not how you create a healthy town, really. I wasn't close to it, but I wasn't part of it. We made a bid, but we weren't at the time, so declare an interest. But I just think it's a nonsense, really, to think that a single initiative is going to actually do something. It comes back to that maturity of how systems work, and how we create health and health creation, and what kind of towns do we want to live in. There's just so much, Mike, that I could.
Let me just pass this to Chris. I mean, is this an instance where having central government through the department in Whitehall developing that kind of initiative is the wrong way to go as far as you're concerned? Do you think that needs a more decentralized approach to try to get into the issues that different towns are facing? And maybe to link to that, I mean, we've got a lot of talk about the levelling up agenda, which central government appears to be focused on, and that is an attempt a broad-ranging, not non-siloed, if you like, or across the silos approach. Do you think that has any potential in the context of dealing with health issues in towns?
Again, I think I'd echo the point from earlier on that let's avoid these either-or discussions. I think it's both and. So I'm not a great fan of the highly centralized approach we have in this country to the way public services and government operates. But I wouldn't go from that to say we don't need any central involvement or central leadership at all. I mean, if we're going to make progress on the big public health challenges of the day, it requires a government or governments that are willing to legislate, to regulate, and to tax.
Absolutely.
And that can't be done 150 times through local council taxes. It has to be done once by a government that has the will and can find the way of doing so. It also needs to be multifaceted. So go back to the last Labour government's cross-government strategy on tackling health inequalities. The evaluation of that published in the BMJ probably 7 or 8 years ago now actually said that there was early evidence that was having an impact in stemming the rise of health inequalities and more positively showing some very small reductions beginning to occur. How did that happen? It was action in almost every area of government around full employment, minimum wage, sure start, etc., etc., etc. And it requires a degree of intelligence and foresight in government linked to an ability to join up different areas of public policy around a major social challenge of that kind to be able to get into that position, but critically also requires a constancy of purpose, a stamina that is often in short supply in governments, a willingness to commit to a multi-year programme over many government departments, and then to follow that through around working with local agencies in the NHS and local government. When you express it in that way, perhaps it goes some way to explaining why it's relatively rare to see those ambitious public policy and successful public policy interventions?
Yeah, I mean, let me follow that up then. That very, very sort of pertinent argument about it's neither centralism or decentralism, as it were. You're thinking about a more partnership-based model. We've got a question here about the regional level, which we haven't covered that much in the discussion. So I thought it'd be good to put to you. And this is from David Williams, who says, what do the panel think of the role value of regional tiers in the relationship between national and local? The NHS regions come and go, now increasing focus on ICS as the principal system level. On public health, regional directors in Public Health England, the first port of call for national government, and that was the initial route for local engagement. In social care, not really any system going into the pandemic. So now have much more direct national to local engagement that has had to be built up. Does that make sense to you both? Particularly Jeanelle, you talked a bit about it.
Yeah, so I think this is a very live issue, let's say, with the proposed changes to Public Health England, or the discussion about. We haven't seen any proposed changes yet, so it's very live. I think there's different. Chris said about geographies. There are different geographies in terms of region, and local government doesn't recognise the NHS regions, and so there's and they're different levels of geography, and it makes sense depending on the place as to the size of that. I think if you follow the principle of subsidiarity, you start with the smaller or the local, and then you build up as makes sense, depending on the issue or what you're trying to achieve and the outcome. And I think local government that's how it drives itself to want to cooperate and work in that way. And then you have something like the NHS imposing down on particular geographies. And I think that is a bit of a sticking point and a difficulty. I think with COVID, different geographies have emerged in different ways, and people have made it work. In terms of public health specifically, on health protection, we absolutely rely on the regional Public Health England teams. I mean, that's where nowadays, not when I first trained, that's where nowadays the health protection, the consultants, that's where that expertise resides, and then works really well with us locally. With some of the other functions like public health input into the NHS or improving health functions, those I suppose could work at different geographies depending on what it is that you're trying to do. But the idea that there needs to be a hierarchy, that you go national, then you go regional, then you go local, I think with COVID that hasn't quite worked. So the local directors of public health have fed directly into national, whether it's chief medical officer or some of the ministers or civil servants, and we're able to do that with our PHE director, regional director colleagues. However, there's also some of the national top down, the regional level protects us from quite a lot of that shenanigans, which we're very grateful for. So I suppose I don't know. I think we're still kind of really trying to get to grips with what that level will be. And with Public Health England being split into a health protection kind of National Institute of Health Protection, be interesting to see what happens in terms of the regional. Very keen on that. The other thing I haven't mentioned is data and intelligence, which the strength lies at region. So in terms of health protection, we're absolutely reliant with COVID and everything on having reasonably a strong level there to support us locally. With health improvement and other things, it'd be interesting to see what that mix is in terms of, as Chris says, the national, fluoridation or smoking tobacco, and then regional and then local. There's a different kind of a mix depending on the issues you're talking about.
Strongly echo that point about the local level data, as we find in the it's incredibly patchy at best. Chris, do you want to speak briefly to that point before I put a last question to you both?
No, I don't feel I have a lot to add to what Jeanelle said, Mike, so I'll pass on that.
Great. Okay. Well, we've come towards the end of our time, so I'm going to put one last question to you. Before I do that, just thanks and apologies to those of you who put questions that I haven't got to. I tried to pick out those that went with the flow of the conversation, but there are some other excellent questions there, which I know I can get both Chris and Jeanelle to look at, and they may pick up after the session. But to close, we were talking before the session began, I think, about the need for optimism, and which feels increasingly important as we go deep into this lockdown. So I just wanted to finish by asking each of you to think of one thing, one particular lesson, or maybe even an example that we really should see as a positive legacy or outcome of the crisis we've lived through, particularly perhaps in the context of the theme of this decision about local decision making, community level engagement. I mean, is there one or maybe two things, if you can be brief, that you would just pick out and say that we ought to reflect further on that or build upon that? Who would like to go first on that one?
My one, if I go first, would be I think the benefits we've seen in some aspects of the response, and this is much more at a local level than at a national level, of partnership working between public bodies. And sometimes that's involved the voluntary and community sector as well. I'm obviously thinking partly of the NHS, but I'm thinking beyond the NHS into the developing relationships with local authorities, which I think at their best have been really powerful, and they've been partnerships of equals. And I hope we've got to the point now where they can't go into reverse, because it seems barn door obvious that this is the way we need to grow and develop in future.
Thank you. Jeanelle.
So that was going to be my point. So I'm going to make another one, which is more about the directors of public health. I mean, I think a real positive is I don't think anyone had heard of us beforehand. I think we've raised our profile hugely. I think the fact that we do are able to speak directly to ministers if we need to. I mean, not often, but you know what I mean. I mean that is remarkable, or other people that we are invited or thought of a little bit as afterthought, but less afterthought than before. I suppose answers on a postcard. We'd be really keen to know how can we maintain that position and strengthen it, and move on from potentially being perceived as only about COVID or communicable diseases or health in a very healthy kind of way, and move on to what we've been we came into local government to do, which was the social determinants of health, and the wider determinants. How do we keep our leadership, our system leadership, and that recognition to continue with that huge work that's needed now, post-COVID or during COVID, living with COVID even more.
Can I just add a coda to that?
Quick coda,
30 seconds, which is, let's hope the people designing the new National Institute for Health Protection aren't tempted to say the experiment of putting public health into local government has failed, and we need to renationalize it under the brand new body. I've only had one conversation with the people who are doing some work on this, and I didn't get the sense from that they wanted to at all move in that direction, but you never know.
We'll send them to go and talk to Jeanelle before they go anywhere with that. Thank you both very much. It's been a really rich and very interesting conversation. Covering obviously lots of issues to do with the pandemic, but I think particularly the conversation about the sort of structures within which you're working in public health, its relationship with the health system, but also these questions about the different layers and how the sort of partnership model that you're talking about, Chris, and how that might develop in the context of the health service. But I think that goes for public policy challenges across the board in many ways. So incredibly rich, very interesting. Thank you very much. Thank you all for dialing in and joining us, and for your questions. And please do go to the CSAP website for details of the next events in this series. Thank you very much.
Thank you.
Thanks very much for having us.